Good morning, everyone, respected chairpersons and all other speakers. My talk is on optimizing outcomes of trifocal IOLs. My name is pronounced as Dr. Tanie Natung, and I am from Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences, Shillong. So, for optimizing outcomes, we have to have certain considerations, which are preoperative considerations and surgical considerations. In preoperative considerations, we should have proper patient selection, precise biometry, correct IOL power calculations, other diagnostics, and patient counseling. So, in selection, we should look into the patient's lifestyle and personality, like occupation, hobbies, daily activities, patient's personality, like there should not be any unrealistic expectations or type A personality. And we should look into the patient's needs and preferences for distance, intermediate, and near work. Then we should rule out certain ocular conditions in the patient, like corneal and external eye diseases, like pterygium or blepharitis. We should be treated beforehand. And if there is astigmatism or more than 0.75 diopter, better to put trifocal toric IOLs. And dry eye should be managed properly, because abnormal refractive surface causes will cause dysphotopsia. And also we should rule out previous refractive surgery, because there is loss of contrast sensitivity, and zonular weakness, because it will cause IOL decentration or tilt, leading to dysphotopsia. We should also rule out pupillary abnormalities, because good pupillary centration of IOL is required for good outcome. And retinal and optic nerve pathologies like glaucoma and macular disease are also associated with decreased contrast sensitivity. And we should look into the angle alpha and kappa, because temporal decentration will cause photic phenomena. Coming to the biometry, precise biometry is very important, and optical biometers are recommended. Immersion biometers can be used, but contact biometers are not recommended. Do keratometry before tonometry, PECI, or A scan. A patient wearing contact lens should be advised to remove these 1 or 2 weeks before taking care readings. Make sure the eye is well centered. Coming to IOL power calculations, newer IOL formulae are recommended, like Barrett, Universal 2, or Hill RBF. These are freely available online in APCRS websites. These are the links that is freely available. And if we feed the data into this Barrett Universal 2, we'll get the power, correct power. And also for Barrett toric calculator, if we feed the data, we'll get the proper axis and the correct power. So we should target emmetropia, and if there is more than 2 diopter difference in the IOL power between two eyes, we should recheck. We should also be mindful of angle kappa, which is the angular distance between the pupillary axis and visual axis. If these are large, this can lead to glare and halos. There is some indirect way of detecting the total eye aberrations. So in IOL master, if you see in the white to white area, if px and py magnitude should be less than 0.6 mm. If it is more than that, there's likely to have more peripheral aberrations. Similarly in Leinster, so we should avoid in such cases. Similarly in standard K values, if K value is more than 0.2 diopters, this may give us irregular astigmatism and lead to refractive surprise, so we should be mindful of this one. Similarly, angle alpha is the radial distance between the limbus and the visual axis. This can be detected by eye trace, which everyone may not have. But coming to other diagnostics, retinal OCT is very important, because some subtle conditions of retina may not be picked up by clinical examinations like ERM, VRT, or RP changes even by retinal specialists. And uh, patient counseling is very important. We have to give some extra chair time for these patients, give enough time to patients to decide, and explain the limitations of the technology, under promise and over deliver, because this is a one time opportunity to change the lifestyle of a patient. And we must involve other key decision makers in the family. So before surgery, who are the good candidates? So those who are free from ocular comorbidities, those who want to be less dependent on spectacles, and patients who are well motivated, no undue expectations, and those who are likely to accept some amount of imperfections. So poor candidates are the opposite, those who are having ocular comorbidities, highly critical patients or perfectionists, nighttime drivers, those who have very dense cataracts and weak zonules or pupillary abnormalities. So coming to the surgery per se, we should have a very round and central rhexis, and there should be good overlapping of IOL over the rhexis. Otherwise, there may be tilt or decentration. So we should make sure that the rhexis is very, very circular and central, like this one. So as far as possible. And in cases of toric IOL, we should make sure that the dots are aligned with the pre-marked axis marking. So here I'll just show a. Excuse me, this video is not playing. I'll just show from the directly from the video. Okay. So implantation of trifocal IOL is same as any monofocal IOL. Here we should make sure that we go behind the IOL and remove all the viscoelastics so that there is not much movement or decentration, and the IOP at the end should be optimum so that it is well centered. And similarly for trifocal toric IOL, initial markings are done, and then rhexis, as I said, should be very circular and well centered as far as possible. Markings are done, axis markings are done, and after good phacoemulsification, we put the toric IOL and remove all the viscoelastics and make sure that the IOL is well centered. Sorry, because of this. Then post-op, we make sure that the IOL is well centered, like even if that in dilated positions. So there are certain limitations, but like residual refractive errors, in such cases we keep a gap between surgeries of 2 eyes of approximately 3 to 4 weeks and see the refractive outcome in one first eye, and if any residual error is there, we can adjust in the second eye. These photopsia like halos and glares are very negligible in the newer trifocal IOLs. Neuroadaptation does take place, and these are minimal compared to bifocal IOLs. So my take-home message is careful patient selection, precise biometry, correct IOL power calculation, proper patient counseling, and good surgery are the keys to success. Few limitations are there but can be overcome easily. These are my references. Thank you very much.
Thank you, Tanie. Um, just a quick question here. How do you center the IOL in the visual axis on table?
So we take the help of the microscope, 3 points, and ask the patient to look at those lights and then try to center.
Because I was seeing your video, it was very well centered, and
Yes,
both
yes.
the Purkinje images were overlapping each other. So
Yes,
that's how I would actually center it. So get the both the Purkinje images one over the other, and
yes,
see
yes.
to it that the central optic is in that
Yes,
zone.
yes, that is the idea. So how we get help is ask the patient to look at the microscope lights. So anyway, thank you very much.
Thank you very much, doctor.